So the plan for today, at minimum, to go over the anatomy of an eye and to discuss the mechanism of accommodation, how you change your focus from close to far. Okay? We're going to start with so-called accessory structures for an eye. So, well, eye is a sphere. Okay? Shouldn't come as a surprise for you. Okay? And it contains the highest percentage of sensory receptors. So it is protected by fat pads and by the bones. There are five bones that form the eye socket. That would be the maxilla, the zygomatic bone, the frontal bone, the sphenoid bone, and the ethmoid bone. Yeah, I believe so. So, eyebrows. The role of eyebrows, come on, sunlight, not really, but sweat. They prevent sweat from getting into your eyes. They're not terribly successful at it if you ever sweat really heavily. So, and then we have eyelids. So eyelids, the fancy name for them is palpebrae. Okay? You will be potentially surprised, but when you close your eyes, that line that separates your upper and lower eyelid is called a palpebral fissure. The corners of your eye also have fancy name. Those are medial and lateral commissures. And this is your palpebral fissure. Within your eyelids are tarsal plates. So tarsal plates, it's a small, tiny little bony structure. Okay, not even bony. No, it's more of a connective tissue structure. They connect the muscles such as levator, palpebrae superioris, and orbicularis, so you can open and close the upper eyelid. Because if you think about this, the only eyelid that you can move is the upper one. And if you look at the name of that muscle, levator palpebrae superioris, it's fancy Latin, but it makes perfect sense. Levator, like levitate, lifter, palpebrae, eyelid, superioris, upper. You do blink. Blinking lubricates your glands with a mucus that is produced by conjunctiva and by the oily secretion produced by tarsal glands. These guys, okay? These tarsal glands that produce the oily stuff to prevent your eyelids from sticking together. And also, Salem, can you suggest which glands produce what effectively is saline that lubricates and washes the surface of your eye? Tear glands, yes. Okay? So, we'll get to them. Now, blinking, regular blinking, produces the lubrication, but if you consider touching your eyelashes, that also may trigger blinking. Does that make sense? It's a protective reflex that allows you to close your eyes the minute something comes super close to them. Okay? Now, this is one of my favorite portions. So there's lacrimal caruncle, produces Sandman's eye sand. You know when you wake up sometimes, and there's a little tiny, like, scruple, yellow-colored scruple in the corner of your eye? That's absolutely normal. That's Sandman's eye sand. Okay? Now let's get to conjunctiva. So conjunctiva is the mucous membrane that covers the anterior surface of your eye. So right here, you can see that conjunctiva can be separated in two distinct parts, bulbar and, well, they don't have palpebral, and palpebral conjunctiva. So let's take a look what's the difference. So bulbar conjunctiva is this. It covers the eye surface. Palpebral conjunctiva covers the inner surface of your eyelids. If you pull an eyelid down, what you see, the pink layer, is the palpebral conjunctiva. And when you insert contact lenses, you insert them essentially in the gap between the bulbar and the palpebral conjunctiva. And that gap is called conjunctival sac. Anatomists really went to town on the eye, naming each and every structure in it. Now, conjunctiva, as I mentioned, produces mucus secretions. Okay? So we can assign tarsal glands, oily conjunctiva, mucus. And if you look at conjunctiva, you can notice, like right now, I'm showing you the conjunctiva, the palpebral conjunctiva on my bottom eyelid. It's pink because there are blood vessels running through that mucous membrane. Now, this is the reason why conjunctiva does not cover the part of an eye named cornea. So here, cornea can be seen as this area. Think about this. If there would be conjunctiva covering that region of an eye, instead of a clear picture, you would see something really, really fuzzy with a bunch of blood vessels in front of your eye. Okay? Now what about tears? So tears produced by a lacrimal gland, which is located in the upper lateral aspect of your eye. Lacrimal gland produces tears which contain antibodies and lysozyme, antibacterial protein that non-specifically kills mostly gram-positive bacteria. Obviously, also it's water, it's some sodium chloride, okay? So the tears flow from the lateral to the medial commissure. You can see the direction of the flow here. And then they drain through the lacrimal punctum and lacrimal canaliculus, a little channel, into a nasolacrimal duct. Nasolacrimal duct connects the medial commissure of your eye with your nasal cavity. This is why when you are crying, you also get sniffles. All that excessive tears end up in your nose. And when you have stuffy nose, you have a little bit of teary eyes, because your stuffy nose blocks nasolacrimal duct, and tears get backlogged, backed up in your eye. Now the eyes moved by the extrinsic eye muscles. We discussed them extensively when we talked about the control, the different cranial nerves. These muscles are controlled by 3 cranial nerves. Oculomotor controls 4, abducens and trochlear control 1. You do not need to know which muscle is controlled by which nerve for an exam. Okay? You do need to know what each muscle does. Okay? Good? But I will ask about that, and you should be able to identify those muscles on the images, but you don't need to know what nerve controls it. So let's take a look at these muscles. First and foremost, there are 4 rectus muscles. Does anyone have an idea what the word rectus means in Latin? I bet you do, you just don't realize it. Have you heard a verb to rectify? What does that mean? If I rectify the situation? Correct it. Can I say I straightened it up instead of corrected? Yes? Rectus means straight. That's it. Okay? For instance, there's a muscle called rectus abdominis. That's a six-pack. It's a straight muscle of the abdomen. So, this is lateral rectus. How do you know what a specific muscle does? How can you figure it out, folks? You pull on it. So if you pull on the lateral rectus muscle, which way would I turn? To the side, to the laterally. Okay, because that's also the side I can turn my right eye to the left. Okay, so laterally. Okay, then we have superior rectus muscle. What if I pull on it? Which way will I move? Huh? Nope. Superior rectus. Yes, up. You pull on the eye, it looks up. Then we have lateral rectus. Medial rectus. If I pull on the medial rectus muscle, where would my eye go? Where would it look? No. Lateral, laterally. Medial, medially. When you do this, when you play like a cross-eyed person, like this, that's medial rectus. And finally, in this image, you can see inferior rectus. You pull on it, where does the eye look? Down. Now, we have a couple of oddballs. We have inferior oblique, and we have superior oblique muscle, which goes through a little connective tissue structure called trochlea, which quite literally means the pulley. Okay? So these muscles, inferior oblique, raises your eye and moves it laterally, sideways. Superior oblique depresses the eye and moves it laterally as well. In other words, if you look at me right now, and I need to look with my right eye on the ceiling, sideways, like this, my right eye is moved, in addition to everything, by inferior oblique. Okay? If I need to look at my elbow without turning my head, right eye to right elbow, that's going to be superior oblique. That moves it sideways and down. Does it make sense? Yes? What if your muscles, one of them, doesn't work properly? People develop a condition known as strabismus. Hang on. We'll get there about correction. So, obviously, when your eyes cannot properly coordinate their focus on the same spot, you're going to develop what's called diplopia or double vision. Okay? So, if there are so let's start with this. If the cranial nerve is damaged to the degree that it's not going to be restored, like let's say something happened and your abducens nerve got wiped out on the left side. Abducens nerve controls lateral rectus. The muscle won't be able to move laterally. Instead, it will move centrally, So you will develop esotropia. Okay, hang on. You don't need to remember all different types of strabismus. Esotropia, exotropia, hypertropia, or hypertropia. No. However, what if the muscle is weak? Okay? Understood? What's going to happen then? You can put a patch on the healthy eye so that eye, which muscles are weak, can train. What if muscle is too long? Can you fix it? Yes. Certain surgical procedures just leave me speechless. So a surgeon would reattach a muscle to your eye in a different location so to correct your strabismus. It can be done. Okay, which is kind of crazy. So now let's talk about an eyeball, and there's going to be a lot of conversations. So first of all, I recommend to draw an eyeball. Let me show what I mean by that. Do you need to be perfect in this drawing? No. I draw an eyeball for this example as a square. Okay? So it is, eyeball is, you know why square? I suck at circles. Okay? By the way, the program can do it, but I'm too lazy for this. All right? So, this eyeball is unevenly divided by lens. Okay? The part that is in front of the lens is called anterior segment. The part that's in the back of the lens, it's called, surprisingly, posterior segment, or sometimes the common name is vitreous chamber. Okay, sounds good? Vitreous chamber is filled with the vitreous humor Any idea what humor means? Obviously not something funny. Humor means fluid. That's it. Ancient Greeks believed that humans are governed by four humors. I can't remember, so it's bile, blood, phlegm, urine? I'm not entirely sure about the fourth one, okay? So we inherited the Greek word humor to describe something liquidish. Vitreous humor actually is, vitreous humor is sort of a gel-like substance. It is formed during your embryonic fetal development and stays with you for life. It doesn't change, okay? And FYI, not for the exam, but vitreous chamber is what's called immune privileged site. It means that your immune system does not really reach into that part of an eye. Okay? Now what about anterior segment? Anterior segment is filled with aqueous humor that is produced right here, AH, aqueous humor, so-called ciliary body. Don't worry, I'm going to go back to the photograph and we're going to go through that one more time. Okay? Now, aqueous humor has to drain somewhere. Would you agree with me? And it does. Turns out your anterior segment is divided by this muscle called iris, the one that constricts and dilates, the pupil. The pupil, so that opening is a pupil, allows aqueous humor to drain, okay, into the front part and eventually leave the eye through the corneal scleral junction. There is a venous sinus there. Okay. Now, you can see that the anterior segment is divided into two compartments. Okay. So AC, I use AC, it's not an official acronym. I use it for my drawing. The front part of the anterior segment is called anterior chamber. The back part is called the posterior chamber. Good? Now, so you can see like a couple of differences. Posterior segment is bigger than the anterior. The vitreous humor in the posterior segment is not produced and not drained. It stays with you forever. While the aqueous humor that fills up anterior segment is produced and drained. Also, anterior segment is divided into the anterior and posterior chambers. Now, let's take a look at this image first. So this is lens, the structure. So this division here breaks it down into the posterior segment and anterior segment. Now, within the anterior segment, you can see the division produced by the, so this is iris, so that small space is a posterior chamber, while that space is the anterior chamber. This conversation, I know, this anatomical terminology is quite confusing. We're making sense. So now let's talk about, highlight some stuff that I've already mentioned. So, lens separate the segments. Aqueous humor fills the anterior, vitreous fills the posterior. Vitreous humor basically supports the eye and contributes to intraocular pressure. Okay? Allows your eye not to collapse. Okay? Now, chambers in the anterior segment, separated by iris, as we mentioned. Now, let's take a look at the formation of the aqueous humor, shall we? So it is formed right here. It's formed right here in this structure called ciliary processes. Then it flows from the processes all the way through the iris down here to scleral venous sinuses where it drains. You good? So the function of that aqueous humor is to supplies nutrients and oxygen to the cells of the lens, the cornea, and take away the waste that they can produce during their lifetime. Now you can imagine that if this production and drainage are unbalanced, especially if your ciliary processes produce more fluid than is drained, fluid will accumulate in the anterior chamber, and it will increase intraocular pressure and will lead to a condition known as glaucoma, which we'll cover today, but separately. So the eye, the eyeball, the ball, consists of three layers: fibrous, vascular layer, and the neural layer. So fibrous layer, as you can guess from the name, consists for the most part of the connective tissue. It consists of two layers, sclera and cornea. Okay? So sclera is the white of an eye. I'm going to use this image to illustrate some of the points that I'm about to make. This is all sclera. Sclera is continuous with the epineurium of the optic nerve. And what's interesting, it is also continuous with the dura mater, okay, that is essentially an epineurium of the optic nerve. Sclera is the tough connective tissue, irregular, dense, and its function is to provide the site of attachment for extrinsic eye muscles. Now this part of the fibrous layer right here is cornea. So the surface of the cornea, that is the ventral surface, the surface on the outside, constantly experiences the onslaught from the environment, and the cells have to be able to be replaced. So it turns out that the outer layer of cornea is stratified squamous epithelium. What about the inner layer? So the inner layer consists of simple squamous epithelium. Do you think cornea contains any blood vessels? No. Because if it would, think about the direction of light. Light comes through your eye like this. Okay? If your cornea would contain any blood vessels, you would see them. However, it contains a bunch of nerves. This is why if you touch your eye, you're going to be blinking and teary. And what is the importance of that protective response? Because we usually don't just stick our fingers in our eyes, right? What's the importance? Protect from what? Yeah. If like a speckle of dust, and that happens all the well, let's say it's a large speckle of dust, ends up on your cornea, it will induce blinking and tearing to wash away and remove it. Okay? Now, since cornea has, it can be damaged, it can regenerate. Now, it doesn't have blood vessels, which means it does not produce any immune reactions, which means it can be transplanted from person to person, corneal transplants. And the risk of rejection is low because there are no blood vessels. There is only one problem with that statement that I made many years ago. Since then, epidemiological data appeared, and turns out these corneal transplants are not terribly successful, just in general. Another clinically relevant thing here is corneal scarring. Does anyone here wear contact lenses? Yeah? Do you just pop them in and go with them for 2 weeks? Yes. And you should. Huh? Yes. Because your eye is exposed to everything, and if you trap microorganisms between the contact lenses and your corneas, the only food that they have is not lenses, it's your cornea. And they're going to damage it. And during repair, if scar tissue is formed, your cornea is not as good as it was. Make sense? We will get to the general concept of LASIK. They don't peel it, but they do some stuff to cornea. Okay? Now, here we have vascular layer, which consists of 3 parts: choroid, ciliary body, and iris. So choroid, shown here as the red layer, provides oxygen, basically provides blood supply to the most of the neural layer in the eye, to the actual part that sees the image. Then we have ciliary body here. So ciliary body is a circular structure, and I cannot stress enough how important what I'm about to tell you. So let's say this is your ciliary body, before I get in the weeds here, contains structures that secrete aqueous humor, right? And it also contains what's called a ciliary muscle. It's a part of the ciliary body. We're doing all right? Yeah? So, I'm going to draw something. So this is your ciliary body. When you look at it from the front, does that make sense? Okay. Curious if I can feel it. Probably can, but no. Whatever. Okay. Now, when you look at the beautiful photograph that you have, you can see that lens the second refractory structure in your eye here is hanging, right? It's suspended within the body. So that would be here. Does that make sense? You will see, and it is suspended by the little ligaments called suspensory ligaments or ciliary zonules. So that's your zonules. Now, I told you that this is a muscle. So here's my question. Listen. When muscle contracts, what happens to its length? It's a simple question. It shortens. If the muscle is circular, when the circle contracts, what happens to the circle's diameter? So this is contracted muscle. Making sense? Okay. Now, it means that your lens is going to be hanging in much slacker zonules. That will become very important when we will talk about accommodation of an eye. Okay, sounds good? So far, we covered choroid and ciliary body, ciliary muscle. Now, what about, and how about that, folks? I am going to focus on the images rather than just reading the text for you. You can read the text yourself. Okay? So what about iris? Well, this is your iris. Right in front here. Okay. It consists of two muscles. One muscle here is called sphincter pupillae. What do you think it does? Sphincter. Squeeze. Yeah. Squeezes. Huh? Yeah, that muscle. Sphincter pupillae. When it contracts, you see it's a circular muscle. When it contracts, its diameter decreases and we constrict our pupils. Okay? No. Pupil is a hole.
It's the little black part in the middle of your eye.
That is a pupil and it's literally a hole. It's an opening. I will explain later why it looks black. Okay, sounds good? Okay. This muscle right here is a dilator pupillae. This is the radial muscle. So it pulls like this, pulls to the sides, pulling the edges of the pupil out, and it dilates. Clear? So the circular sphincter pupillae is controlled by parasympathetic system. It is activated by parasympathetic system, and we already learned that parasympathetic activation constricts your pupil. Dilator pupillae is activated by sympathetic system, and we learned that sympathetic activation results in the pupillary dilation. The color. What determines the color? Pigment called melanin, the same pigment that determines the color of your skin. Okay? So, depending on how much pigment you have in the iris, it will determine the eye color. The more pigment you have, the darker your eyes are. Okay? Does it make sense? All good?
Yeah, can you answer that last question?
Well, can you? In the baby born, it's okay. Green eyes, first, okay, let's start with this. Albinos. They have red. Because of blood vessels, because they don't produce the pigment. And the pupil is also kind of reddish. One of the reasons for it is because choroid layer is super dark. Okay? And it also absorbs light. Now, I want you to think about something for a second. Let's say that inside of your eye, just for the sake of, conversation, has no pigment and it's as white as the white of an eye. So if the light, when the light hits your eye, it will be reflected by the white surface. And it will start scattering in your eye. And your vision's not going to be good. The pigment in choroid absorbs light and prevents its scattering. Does that make sense? So, people with albinism, would they have some sort of visual impairment? Sure. Because they don't have that absorption. Okay? Now, going back to this. If green eyes have low amount, if gray have a little more, and brown have the most, why? Some babies change their eye color from gray to brown. That's the question that you're supposed to answer. You have all the knowledge. It's very simple. It's a very simple answer. When they have gray color of the eyes, do they have a lot of pigment? When the color changes to brown, do they have a lot of pigment?
Yeah.
They just produce more pigment. That's it. Okay? No. No.
My son had gray eyes when he was born, and they now
Sure.
like brown.
Sure.
So that's
Yeah.
why I wanted.
That's why that he was also.
Very
It is
light.
known that for people of African descent, in many cases, the newborns have the lighter skin than the parents,
Yes.
and then it's getting darker
It get darker.
because they produce. That's a genetic feature. When they age, they produce more melanin. That's all. Okay. Retinal layer. So retinal layer is effectively an extension of the brain. Okay? So it contains two sublayers. Let's break it down. First, and we can say the most important, is neural layer. So neural layer, this one, okay, contains neurons or modified neurons known as photoreceptor cells. And then we have pigmented layer, which consists, well, pigmented cells. Okay? So what is the function of these things? Well, as you can imagine, the neural layer, okay, is composed of photoreceptor cells, bipolar cells, which are neurons, and ganglion cells, which are also neurons. So essentially, those are neurons. They transform the light into neurotransmitter / electrical signal that eventually reaches the brain. Okay? The pigmented layer, it prevents scattering of light because of the pigment, and also renews photoreceptor cells. The third function of the pigmented layer is to store vitamin A. As we will learn, vitamin A is essential for the function of the cells in the neural layer. Now, eventually the axons, or so-called ganglion cells, they will form an optic nerve. Now, a quick question. This area, does it have any traces of a retina? That specific circle? No. There's no retina, which means there should be no photoreception there, right? And we should have what's called a blind spot, also known as optic disc. This is optic disc, is where the nerve, the optic nerve, leaves your eye. No. Like, it's in the back of an eye. Like, this is, so your retina is in the back of an eye, okay? Am I making sense? And it all senses the image. And then there's a little blind spot on it, like a broken pixel. But you don't have the broken pixel in your eye right now. Right? The reason? Your eyes are moving all the time. And the part of an image that falls on that blind spot is different all the time. So your brain fills up. Does that make sense? It's like a computer that fills up that blind spot, which is mind-boggling, honestly. So let's take a look at the retinal layer in a little bit more details. So first of all, you can see that there are three types of cells. There are photoreceptor cells, there are bipolar cells, and ganglion cells. And bipolar cells, shown here in red, are positioned between photoreceptor and ganglion cells. Sounds good so far? Photoreceptor cells, in turn, divided into rods and cones. Okay?
Divided into what?
Rods and cones. Okay? You can see that both of them, both rods and cones, are immersed into the layer of pigmented cells. Okay? Now, which cells, based on this image, present in your neural layer in greater numbers? Rods. It actually is tied to the function of both cells. So rods are very sensitive to light, and they work in the conditions where light is dim, darkness pretty much, and they also are numerous in the parts of the retina that's responsible for the peripheral vision. Cones, on the other hand, are responsible for the vision with high resolution that can also see colors. Do you follow my train of thought? Now, I want you to answer a few questions of mine. They are based on your day-to-day experiences. When you walk into, like, let's say it's 6 a.m. in the morning, or 5:30, it's dark enough, okay? And you are trying to choose what to wear in that very dim light, and you don't turn on the light to not wake up your partner. How well can you distinguish colors? You can't. When it's dark, you can't. Because when it's dark, rods step up, and they don't have a capacity for the colored vision. Also, what about the quality of the image right now versus a very dim room? Which one will be grainier? Dim room, right? Rods are not great at resolution. And the same is true for peripheral vision. If I would put someone, like if you're standing, and I will ask someone to walk in a very, like where my hand is right now, more or less. Okay? Will I be able to see that person in details?
No.
No. Will I be able to see the colors of that person's clothes? Not really. It would be anyone's guess. Because that would be rods responsible for that vision. We're going to talk more about this when we get to the transduction. Now, let's talk about this actually very exciting things. Macula lutea, which is translated from Latin as yellow lutea spot, macula. Okay? Yellow spot. As a matter of fact, I mean, it's not super yellow, but if you take a glance into the eye with the ophthalmoscope, you know, the little, like, light that they shine, you're going to see that spot. Okay? What is so interesting about that spot? This is the spot that has high percentage of cones, which means it has high acuity, exceptional ability to distinguish the details. Now, if you look at the structure of macula lutea, it has multiple sub-compartments, let's call them this way: perifovea, parafovea, and finally fovea, sometimes called fovea centralis. Turns out, fovea is really small. It's the diameter of fovea is 0.4 millimeters. Okay? Does that make sense? To give an idea what 0.4 millimeters is, take a penny, look at how thick it is, and take a quarter of it approximately. That's pretty thick. Okay? Am I making sense? And yet, since this is the area with the highest percentage, only cones, not just high, only cones. So when you look at something intently, for example, if I look at the soap dispenser and the word Gojo on that soap dispenser, that word focuses specifically on myopia centralis. Okay? So this is the highest acuity. When you start moving away from fovea centralis to parafovea and perifovea and periphery of the eye, number of cones decreases. Does that make sense? And that's why peripheral vision is rods, and it's doesn't have that high acuity. Now let's talk about the lens. So lenses are a bulging structure Okay? They are flexible and transparent. And the important feature of lens is that they can change shape. It's not a trick question really, but your cornea in the front of an eye, can it change shape? No. That makes sense? It doesn't change shape. Your lens can. So what I'm going to do, I'm going to explain why I'm bringing this up. So look at this. This is the front of your eye. This is cornea. Nope. Just stays there. It's in the place. Just stays. Okay? So, is it straight? Nope. It means that it's going to refract light. Am I clear? So, it's going to change the direction of light. But the direction of light should be changed differently depending on whether you're looking at something close, something far. We call it accommodation, right? And cornea cannot change. It's like you're stuck with a single type of, like microscope with only one set of objectives. And that's it. You cannot change the magnification. You cannot change anything. Am I making sense? So you have a second structure called lens. They can get flatter. They can get bulkier. Okay? When they get flatter, far vision. When they get bulkier, close vision. Well, we'll get to nearsighted and foresighted, why that is happening. Okay? But the point is that lens can change its shape, to change the focal point, to change how far your focus is going to be positioned. Okay? Lens are suspended by ciliary zonules, the ligaments. They do not have blood vessels, otherwise you would see them, but they receive nutrients and oxygen from the aqueous humor, okay? That these black arrows represent the flow of aqueous humor, okay? And cuboidal cells of lens epithelium will eventually form lens fibers, and these fibers are stretchable and contractible. Well, stretchable, elastic. Now, when you get older, the addition of fibers makes your lens less elastic, and your ability to focus on different objects decreases. This is why older people start having deterioration of the visual capacity. Okay? Now, retina, which contains neurons, requires a lot of blood. So blood supply to the retina is carried out by choroid and by capillaries that span from central artery and drain into the central vein. So one interesting, I'm clinically relevant. I'm going to give a clinical connection, folks. You can fairly easily observe the capillaries, retinal capillaries, using a ophthalmoscope. Okay, you can see artery and vein and a bunch of capillaries that they branch into. Can you see that? Yeah? So it's been shown that cardiovascular disease, its first signs, are more noticeable in smaller vessels. So when you go to an optometrist, and they look, or a physician, and they look in your eye, they're not only looking for, I don't know, like, do you have macular leukemia? Yes, you do, right? They look for any abnormalities with the retinal capillaries, retinal blood vessels. Am I making sense? Okay? And if they see it, they can suggest like, oh, it looks like you have hypertension, like pre-hypertension, should probably go see cardiologist. One of the biggest issues associated with the blood supply to the retina is diabetic retinopathy. Okay, so here's what happens. Check this out. This is your normal capillary. It's very thin, but the cells that form it form tight junctions, so there's no leakage out of the blood. In diabetes, the inflammation of those capillaries results in the gaps, and you start seeing blood leakages. And the decreased, hear me out, that's really elegant, and the decrease in blood supply to the retina. Do you think, physiologically, human body senses that there's less blood getting to the neurons? Yeah. So it tries to improve the supply. How? By growing more capillaries. Now, here's my question. Let's say the pipes that lead to your house start leaking, and the water pressure in your shower drops, and you fix for it to put more pipes, leaky pipes, to improve the pressure, right? It's going to work temporarily, but you're going to make the problem worse. This is called proliferative diabetic retinopathy. Eventually, the accumulation of that exudate results in the macular edema, and diabetic retinopathy is causing the most cases of blindness in adults. And people with diabetes, obviously, are susceptible to it. Because they are diabetic, because it's a diabetic retinopathy. Can you prevent it? Yes. You need 2 doctors and self-discipline. You need a good endocrinologist and good ophthalmologist. And you should do the checks of your, like, keep your insulin, keep your blood glucose low, check with ophthalmologist that your eyes are good, and you effectively can outlive diabetic retinopathy. Okay? Am I making sense? No. If you if you have a patient who does not control their blood glucose, say type 2 diabetic person who, I don't know, it's the temple of diabetes food for the morning, it's a second name for Cheesecake Factory, then yeah, they're going to get blind, right? If you have a very, we have a friend who's 70, he has type 2 diabetes for I don't know how many years, but he's being really disciplined, and he's totally fine. His vision is fine. Well, I mean, the age-related decrease in, he's nearsighted or farsighted, sure, but that's not related to diabetes.
So is your eyesight always deteriorating?
It depends. For the most part, yeah. To a different degree. Okay, I have a bit of a, if you are nearsighted, you may have a bit of an advantage. Okay? So a couple more pathologies. So papilledema. Very cool condition. When, remember, eye is connected to the brain, and by connected I mean there's a direct access. So, I'm not saying it as a joke, it's a direct access. So when the pressure in your cranium, the pressure of cerebrospinal fluid increases, it pushes optic nerve and CSF into your eyeball, okay? And that results in the swelling of your retina.
And that way, like, it feel like it's hurting behind your eyes.
It's not as much, you don't feel it's hurting, essentially, because if it's hurting, things getting really bad. What I'm saying is that, and I'm going to be very, like, primitive. This is your eye, this is the optic nerve, and this is the brain, okay? Brain/skull, right? So there's like, here's the cerebrospinal fluid. If CSF pressure increases, it starts pushing from the back to front. That increases the pressure within the eye, causes the damage.
Like when I get sinus infections, it hurt more
That's,
like behind my eyes.
That hurts because your sinuses are inflamed, and some of your sinuses are literally behind your eyes.
Okay.
In the bone, yes. No, it's not that. Pupil edema is common in people who experience frequent changes in pressure. Pressure, environmental pressure.
Stress.
You have to climb a mountain very fast and very often. I'm talking about pilots. Pilots and the crew members on the planes. And that's sort of a professional disease. Not that all of them will develop, but they are at the high risk. Okay? Detachment, right here. Well, pigmented and neural layers separate. Now, why this is bad? Your neural layer is basically neurons. Neurons cannot survive without oxygen and nutrients. So when retina is detached, at some point it starts dying, and it never comes back. That damage is permanent. You can reattach it if it's diagnosed timely. Actually, I have a buddy who also a person that does certain services for me, who has retinal detachment. So one of his eyes is pretty much blind. He got hit in the eye when he was a kid, well, teenager, and they didn't fix it. The interesting thing is who he is. Again, he's practically blind on one eye. He's my tattoo master, and he's fantastic. He's half blind, and yet he's great. Okay? Couple more pathologies, glaucoma and cataract. So we just talked pupil edema, right? The pressure from the inside. Glaucoma is the pressure from the front. So look what happens. Your aqueous humor has to drain into a scleral venous sinus. If there is no drainage, what happens? The fluid builds up in your anterior segment. It starts exerting pressure on your posterior segment. Vitreous humor has nowhere to go and starts pressing on your retina. So what's happening? This is how advanced glaucoma looks with a naked eye, pun intended. And this is the differences between the normal vision and different glaucoma. So you can see that the field of vision decreases pretty much because the peripheral retina gets progressively damaged. Okay? Glaucoma is treatable, can be treated surgically, can be treated with drugs. Okay? Oh. Huh? No. It's not botanical. Dude, I can't remember. Seriously. Okay. It is one of parasympathomimetics. I don't remember which one. So this parasympathomimetic opens up the drainage canal. Right? Make sense? It drains. If it can't, if it fails, if it's not enough, then there's a surgery. Okay? Cataract. Wear and tear, so to say. I almost promise you that all of us are going to develop cataract. Just like we're all going to develop Alzheimer's. The question is, are we going to be old enough? Or are we going to die first? Okay? So, no. So, no. Completely different things. Cataract is claudication of your lens. They become not progressively less and less transparent. To give you an idea, well, my dad is not a good example, but so my dad agreed, begrudgingly though, on the surgery to get lens replacement when he was way into his 80s. Like he was maybe 85, 84. Okay? My mother-in-law had lens replacement before she was 70. My mom, who's 80 plus, still perfectly fine. It all depends on a number of factors. So, diabetes, okay? Oxidative stress, age, just age, smoking, and intense sunlight. Okay? So, depending on your activities, that may be that. And yes, sometimes newborns can be born, some newborns are born with cataract, but that is fixed with the lens replacement. Okay? Any questions so far, folks? Okay, we have a few topics to discuss. Right. Let's see. First of all, this is not a physics class. Hear me out. I want you to understand a few basic physics concepts so we can speak the same language. Huh? First, visible light. There's a huge spectrum of electromagnetic radiation spanning from radio waves to gamma rays, right? We see only a small portion of it, which is visible light. You're probably familiar with the spectra that abut visible light. We use infrared goggles to sense thermal sources, and ultraviolet is what gives us, it's a black light, what gives us tan. Okay? So, within the spectrum, our rods can only absorb a very specific part of it, basically blue light, blue-green, and that's why our rod-mediated vision, dim light vision, is monochromatic. We do not see colors. Is that clear? Cones, on the other hand, can sense or specifically absorb blue, green, and red. Okay? Does that make sense? When these absorption spectra overlap, as you can see on the image, this is why we can see colors. Okay? Sounds good? Little digression, but kind of fun digression. I don't know if there are any computer nerds, but have you heard the term RGB, the representation of color in the computer monitors? It stands for red, green, and blue, the colors that cones perceive. Does that make sense? Does anyone know what this means? CMYK. This is the color system that is used in printing. Cyan, magenta, yellow, and black. K is black. Okay? Does that make sense? We don't need black. For us, for our eye perception, black is the absence of light. Am I clear? So since we're going to talk about eye accommodation, let's focus on refraction. So we have two refractory structures in the eye. One is cornea, and lens. Okay? The only one structure that can change shape is lens. Does it make sense to you? Now, human lens are biconvex. Okay? Now, what are other types of lens? So if we're talking about convex, it will be this. One side is flat, another side is not. The alternative to this is concave. So concave lens. One side is flat, and another side is turned inwards. Okay? That will become important when we're going to talk about farsightedness and nearsightedness. It's not the end of the story, though. Combination of cornea and lens results in the image being flipped upside down and left to right. So if somehow someone would be able to capture the image on our retina right now, all of you on my retina, all of you, the entire room, everything is projected as being upside down and left to right. And yet, I'm not confused. You're good. I understand your position. So how does that work? No. It has nothing to do with physics. It's all about your brain. Huh? But why? How does it know to flip it? So let me ask you this. Did you ever have to deal with little babies, few days, weeks old? Are they highly coordinated? Quite an opposite of that, right? All they can is they cannot even turn. Okay? Basically, they're like turtles if you flip them on the back, right? So when they look at the environment around them, their eyes show them one picture. But the somatic sensations, because they touch everything, show them completely different picture. And there is a conflict, sensory conflict in the brain between the visual inputs and somatosensory inputs. That make sense? And at some point the brain says, to hell with that, we're going to just start flipping the image. That's it. Flips the image. I don't know. I cannot tell. I don't know. But yeah, it's just, screw that. They don't have a lot of high brain processing, so don't feel sorry for them. At this stage, I call the kids zucchinis because they are zucchinis. They have an intellect of a zucchini at this point. Okay, so now let's take a look at what's happening here. And in this case, I am going to use the text. I'm just going to be highlighting the steps. Okay? So, when we operate normally, like right now, all of your lenses are adapted for seeing something far. 6 meters, 20 feet. Okay, so not too close. So what does that mean? When you, let me ask you this. If I will bring you to Lakeshore, in Erie, okay, I will tell you just, just look at this beautiful sunset. Your eyes, do they get tired of looking at the beautiful sunset? Physically. Not mentally. No.
Yeah.
No. You will see what I mean. They're not going to get tired. You may say, okay, I don't want to look at it anymore. Fine. But when you drive a car, your eyes are focusing on the road, hopefully. Okay? And if you do that, you can get bored, but you can drive for hours and hours and hours. Am I making sense? Why? Is because the ciliary muscles, this circular muscle that suspends, that holds the lens inside, right? That ciliary muscle is relaxed. When muscle is relaxed, what happens to the muscle's diameter? When it increases, right? The diameter of the ciliary muscle increases. Let me try to draw it, actually. I'm going to use this color. So take a look. So this is lens. Okay? Lens. This is your ciliary muscle. Okay? So ciliary muscle relaxes and its diameter increases. Okay? So ciliary zonules become tense because muscle pulls on them. Make sense? So what happens to the shape of your lens? They become flattened. Okay? So tension of the ciliary zonules stretches the lens. Okay? And the light is properly focused on the back of your retina. Make sense? Then we have, when we look at something close. So what's going to happen is your ciliary muscles are going to contract. The circular muscle contracts. What happens to its diameter? Say again? Okay. So this is lens. This is your ciliary muscle. So now the zonules do not produce any tension, right? Because of the contraction of the ciliary muscle. What happens to your lens? They bulge. Does that make sense? And that focuses the light that comes from the closer object successfully back of the retina. Am I making sense? Now, if you put together the pupillary activity and the lens activity, like if we want to talk about this as, let's see if I can, yeah. So if we want to talk about this in the paradigm of flowchart, so far vision will be sympathetic activation results in ciliary muscle relaxing, ciliary zonules increase tension, lens become flat, at the same time, because it's sympathetic, right? At the same time, the muscle dilator pupillae contracts, pupils dilate. In case of closed vision, which is parasympathetic, ciliary muscles contract. Okay, so its diameter decreases. Ciliary zonules become less dense. Okay. Lens bulges because of its elasticity, and at the same time sphincter pupillae contracts, pupils constrict. Okay? Sounds good? I'm going to leave it on for some time. Okay? Now, when you read, is it closed vision or far vision? It's closed vision. When you engage in your closed vision, your ciliary muscles, do they contract or relax? Contract. When muscle contracts, does it get fatigued? If you read just sitting in a chair, you're fine. Because there's no shaking, the book is at the same position, right? And these are smooth muscles, so the mechanism of contraction allows them to be fatigue resistant. Now imagine that you are reading a book while walking. Can you do that? I have at least 2 members of the family, including me, who did that. Yes, we ran into objects when we were kids. My son is another member. You can. The book, will it move? Will your eyes have to reaccommodate? So the muscle has to really work, contract, relax, contract, relax. That gets them tired. When I was a teenager and a college student and later, we had a lot of public transportation. There's nothing else to do. You read. And if it's way too long of a commute, you guys get tired. Because, kind of rocks. Now, what about these conditions? Astigmatism, nearsightedness, or farsightedness. So, normal eye is emmetropic. Now, in a myopic eye, what you see is that the eye is too long anatomically. Does that make sense? Okay, it's physically too long. So when your lens focuses an image is focused in front of the retina. So what do? You put concave lens in front of an eye, and they push the image back towards the retina, and that's corrected. Am I making sense? Are you all nearsighted? Nearsighted, yeah? I can probably say who's more nearsighted just based on the thickness of the lens. I'm not going to do the competition, but you can say, because here's the deal. The greater nearsightedness you have, the worse your vision, the thicker the lens is going to be just because of the structure. You have a greater curve. Okay? Make sense? What if you are hyperopic, farsighted? Your eyeball is too short. So you have to put convex, that's biconvex, but you get the gist. And that will correct it and put it back in your retina. So, a couple of things. You're born with that. It's the process of development. When kids realize that they're nearsighted or farsighted, it's not their fault. When I was a kid, and my son still reads a lot, but I used to read a lot. Like, to the point that my mom was complaining because I would not get any shit done. I could stand and read. I could stand in the middle of a road, find a piece of newspaper and just read it. I read anything I could. If that would ruin vision, I would be blind by now. And yet my nearsightedness did not change since I was a kid. Okay? Yeah. No, I don't know. I don't know any. It's a very good question. I'm going to look at genetic epidemiology of nearsightedness. It would be very interesting. Okay? Now, is it 100% genetic? No. Is it hereditary? Not really. I'm the only nearsighted person in our family.
Me too.
Yeah, that can happen. And my parents and my brother are farsighted. Well, they also not. Compared to me, they're older. Not that I'm very young. Okay, so that can happen. Now, what is astigmatism? We're getting to your answer. Say again? So, here's what happens. Usually cornea is uneven. Can be lens too. So what happens effectively in astigmatism is that part of an image is focused in front of the retina, and part of an image is focused behind the retina. Okay? So it can be fixed with special lenses, but what about LASIK? Does LASIK fix your lenses?
Yes. No.
In this case, we'd have to open up the eye, hoping that it will heal back. No. It fixes your cornea. You can think of it as polishing cornea to adjust its shape so it will suit the shape of your eyeball. If you're myopic and it's too long, your cornea will be shaped one way. If you farsighted, another way. If you have astigmatism, it can be fixed also. The astigmatism? I have no idea. But it is not somebody's fault. Okay? Can be, I wouldn't say hereditary, genetic, developmental. So, for some reason, people have uneven cornea because of that. Now, what is mind-boggling? Now it's a laser procedure. Which kind of makes sense, right? Like you cut a little bit of layers here and there. Okay. The person who started it was a Soviet ophthalmologist, Evgeny Fedorov. He opened the first clinic to surgically correct myopia and hyperopia and astigmatism. And it was, I believe, in the 1970s. People, remember, it's Soviet Russia. We had government-sponsored medicine. We really did not, that was a good thing. We did not have like waiting list. If you need a surgery, you're going to get a surgery pretty soon. The wait list in the beginning was about 2 years. There was one clinic in Moscow. People would cross the entire country to get their eyes fixed. The cherry on top, there were no lasers. It was actual surgical tools made out of metal. And there was a microscope, and they would just, muddle around your eye with those tools. Well, you are knocked out, like you don't feel anything, right? But that's what it was. It was probably the most precise surgical tools ever invented by humans.